Now I'd like to call to the podium Dr. Lara Harvey, and Lara will be talking on the impact of adherence to the hip fracture clinical standard. Lara and I actually did our PhDs together, and Lara's a senior research fellow in the Falls Balance and Injury Research Centre at Neuroscience Research Australia, and a senior conjoined lecturer at the School of Population Health at Uni of New South Wales. And I'm glad you've stopped calling yourself a geriatric epidemiologist, because it was making you sound very old. So she's an epidemiologist with interest in expertise in the analysis of large population-based data sets. So welcome, Lara.
Thank you, Rebecca. So what I'm going to talk to you about today is a slightly different type of study than we've already discussed this morning. But before I do that, I'm just going to take you down a trip down memory lane, because we're talking about where we are now. For people that haven't been on this whole hip fracture journey, in September 2014, the first NHMRC endorsed guidelines were released to actually describe what makes good hip fracture care. Exactly 2 years later, the first clinical care standards were released, and the first hip fracture registry report was released, and they've been releasing reports with alarming regularity every year since then. I don't need to labour this point because it's been discussed many times and is about to be relaunched in the next iteration, but there are 7 quality statements supported by 16 quality statement indicators, the last 2 of which are indicators of effectiveness, although I would argue that 6B and 7B are also more indicators of effectiveness also, but that's semantics, and I'm an epidemiologist. I like counting things. So what I want to talk to you about is what I think is terribly exciting. And so it's a linked data project where we've been able to link the hip fracture registry data with a myriad of other administrative data sets. So hospitalisation, death, we actually have activity-based funding, unit record data. We've also linked to Commonwealth data sets. So we have National Death Index, Pharmaceutical Benefit Scheme, we've got residential aged care data, and we also have rehab data. So we can now start looking at outcomes and impacts beyond the acute care and beyond the 120-day follow-up. I want you to put this into context. This is very difficult to achieve in Australia. We're one of the first registries to really try and push the barrow with this. So what I'm presenting is quite old data now, and that's because of the lack of timeliness and being able to access this kind of studies. It also involved 2 separate data linkage units, and it has to be stored in a secure remote environment for which only 2 of us, Morag and myself, are allowed to access. So for this particular study, and this is just a prototype proof of concept study, we're looking at the early days from 2015 to 2018, and only for New South Wales because that's where we had the funding. For this study, we'll be linking, or I did link, hospitalisation, residential aged care and death data. It includes 9,518 hip fracture events, but in 9,336 individuals, which is around about a 2% second hip fracture. So these are patients that have information in the registry. So when we look at indicator attainment, now things have improved over time, obviously, but the first thing for that first 4-year period is that there was a very big difference from 95% of people being on unrestricted weight-bearing status or not having a pressure ulcer. So I've just flipped that. So green means indicator attainment. Orange means that indicator wasn't attained. I originally put it as red, but then I was worried about people being colourblind, so I hope you can see clearly the difference. And the most poorly attained, obviously, was receiving bone protection, medication on separation. Originally, I wanted to model people that achieved all the indicators, but that was not going to happen with only 1% achieving that. So, and we also, I'm only looking at acute care indicators. So what happened at a patient level acutely in the hospital? And so we've settled on more than 6 of the 8 possible indicators, which equates to 75% attainment, because it's not always clinically possible or relevant to reach all of those indicators. So that for us is our measure of high quality care. And that was a third of patients, which also meant I could do some modelling with the data. So not surprisingly, the proportion that attained greater than 6 of these acute care indicators increased over time dramatically, from less than 10% to over 50%, and that's still 2018, and I'm confident that it's increased since then. When we look at who are the characteristics of the patients, and I don't want to labour this too much, just to show that there are some differences. So actually, the younger age group were less likely to receive high quality care. Females were 25% more or higher odds of receiving high quality care. Unlike what we've heard earlier, in terms of whether you were cognitively impaired, there was no difference in proportion in receiving high quality care. However, if you were multimorbid, and so we were able to link in the hospital data to get a really nice indicator of comorbidities from this, you are less likely to receive high quality care. And also, if you came from residential aged care, so again, we can use the residential aged care data to give us a really accurate count of everybody in the registry that came from residential aged care. So I've changed my colour of my graphs. My colour coding is the same. So green are the groups that received what we're calling high quality care. But these are now what I'm calling outcomes, so events that occurred after that. So proportion of patients with hip fracture readmitted within 12 months. Again, we could link in the hospital data to make sure we have this measure for everybody. Significant difference. It's not common anyway, but it was a 25% decrease for those that received high quality care. There was no difference at 120 day for those patients that were from home that went back to home, as measured by whether or not they were in residential aged care at that point in time. We can actually extend that out and look at longer term outcomes now and not just have to look at it 120 days. When I look at reoperation of hip fractures within 30-day follow-up, again, the numbers are very small, and that's really gratifying. But again, there's a significant reduction in the group that received high quality care in that indicator. And obviously important survival at various different time points. So 30-day mortality was halved by that group that received 6 or more indicators. This was sustained over time, and so really this is the first study that, as far as I'm aware anywhere, that we've been able to show improved sustainment over a longer term outcome. But what I hear you all asking is, but we know that there's different patient characteristics. Totally, so they're unadjusted. So what we can then do now is we can model and we can start explore which of the indicators particularly are associated with outcomes. Given that this is a small sample size, you have to be a bit careful, but so obviously also geriatric management was so to put my graph in context, the blue dot means it wasn't significant, red dot means there was a significant reduction, and the green dots at the bottom are the aggregated when you have 6 or more of the quality indicators met. So also geriatric management reduced mortality at 30 days. As we've heard, surgery at 48 hours reduced mortality at 30 days. Being offered, and this unfortunately was just offered mobilisation because it predates counting whether they were mobilised, but it's clearly protective. Now that may also reflect the type of patient that was offered that. Not having a pressure area, and again being offered bone protection medication. When we look at that overall, we have a 50% reduction if you attain more than 6 of these. But the last bottom line of my slide, which I think is the most exciting one, is that when we adjust for everything that we can possibly adjust for, age, sex, comorbidity status, pre-fracture mobilisation and mobility, whether they came from residential aged care, the year, and also characteristics of the operating hospital was included as a random effect, that decrease remains robust. So it's not being driven by patient or hospital characteristics per se. When I look at the same graph on 1-year mortality, the pattern is very, very similar. One notable and interesting difference is also geriatric care increases, or it doesn't increase, this is not causality, it is associated with a higher risk of mortality at 1 year. And again, that decreased association at 1 year is robust to adjusting for patient and hospital level characteristics, which is the bottom line. So this study suggests, and again, we cannot assign causality in these kind of studies, but it suggests significant health benefits in terms of lower fracture rates, rehospitalizations, and significant survival benefits with adherence to clinical quality indicators. It also demonstrates a year-on-year improvement in adherence following the introduction of this guideline standard registry combination. Short-term survival is doubled when greater than 6 of the indicators are met, and this, I think, highlights the cumulative impact of a number of steps in the hip fracture journey rather than one or the other. It's the first study internationally, as far as I'm aware, that demonstrates increased survival is sustained at 1 year. And it also really highlights the role of orthogeriatric care. You know, this is a frail older population. Death is not unexpected. And increased risk of life at 1 year is expected. But should we also be measuring other quality indicators of quality of life or other indicators that are more meaningful for patients? And that's what we've been hearing through some of Elizabeth's work as well. So directions for future research, I was only given 10 minutes, so I could tell you lots more, but we've been very fortunate that we were funded to replicate this in a national. The NHMRC provided some funding to do a national linked data study, WA, with the exception of WA, because that's very difficult to achieve. With that, we'll have much larger sample size and more recent data. We are still negotiating to have WA data. It's taken exactly 4.5 years for this project to get through the negotiation. But I'm happy to say about a month ago, I actually got the data. So that's going to be very exciting. You know, we can do further exploration of which indicators are strongly associated, and we can look at a much wider, longer time period of outcomes. You know, I think we need to be thinking about how we can have more robust analysis of healthcare measures that are meaningful to patients, which we've been hearing a lot about today. And for me personally, I think this is the way that research and registry data really needs to go, where we can harness the information that's already available in administrative data sets, and that it needs to be a sustainable model, not reliant on grant funding. You know, it's cost effective, but also that timeliness of the data, so that when we do come and report these kind of studies, we're talking about last year's data. And I just would like to acknowledge the Agency of Clinical Innovation that funded the study, the NHMRC that funded the national study, and my co-investigators, several of whom are in the room today. And I think Rebecca's going to crash tackle me, so I better finish there.